Following up on the agenda, I'm going to invite Pedro Pita Barros on stage. I have a very hard time going through everything that you have studied, done,
Don't worry.
been awarded with. So most of these people know you, but I just leave it up to you. Thank you very much for being part of this today and for researching on top of data as well. So we're listening to you.
Thanks for the invitation, and it's a pleasure to be here. I think that the only thing that I am known is that I have an office up there that has a view over the ocean. I think that's the most famous thing here that I have. What I was asked to talk to you about was the role of data in health economics, which is nice, because here, I guess that you all know about data. You have more knowledge than I will ever do about it. So I'm going to talk about more the health economics part. And actually, I'll try to figure out with you whether you have a good sense of what is health economics, and then how data will be able to contribute to what we do in health economics. When we talk about health economics, probably you have in mind that we are kind of computing everything and putting accounting numbers in everything that you do or intend to do. Well, that's partly true, but it's also true that health economics actually covers many other things. One of them is starting with health itself, even before the economics. It's what is the meaning of health? How can we get subjective and objective measures of health? What does it really mean to measure health of people? And that's one of the things that take us a lot of time in economics to understand, so that we can then think about how decisions are made related to health economics, to the health production and the health promotion and all those things. And that's going to be a big part where data can come in with specific features. The second thing that we look on, that we could expect, is the production of health. What does that mean? And for that, you're going to have two different things contributing. What people do, what are the behaviors of people, and what is healthcare that is mixed with that part. And if you think carefully, when you talk about health, you have a major issue that you don't have in other areas. Have you ever tried to buy 5 liters of health or 2 kilograms of health? Have you tried to find health cans in supermarkets? You don't find them. So health is a particular thing because it's a mix of your time, your body, your characteristics, your behavior, and healthcare. Healthcare that you don't buy, that you have it prescribed most of the time by someone. So we have lots of behaviors involved in here, and then we have to learn how those behaviors evolve, what determines them, how we can eventually direct them. And for that, data will be useful as well. Well, as I'm an economist, so as you could expect, I always care about demand and supply, right? If you want to have an engaging conversation with the economist, you can always start by saying demand and supply, and you get him on board. Now, here, demand and supply will mean many other things. You're going to have different ways of balancing markets, not only the price instrument, as we usually do in many other markets. You're going to have to, in some cases, having matching of organs. Matching. In one of the cases where you have matching is matching of organs to donors and people that need them. How to organize those markets. You may also have matching between you and your physician. I wonder, when you decide that you want to have a look at you by some physician because you feel strange about something in your body, do you go to the yellow pages online? How do you work for that? Do you go for the first one that you see on the street? Do you look for advice from friends, for specialists? Dr. Google nowadays? Those things will be decisions that will matter for demand and supply, and those will have a specific role for data in this decision process. And another topic of research in health economics is health insurance, either public, being the National Health Service, a public health system, or private. And for pricing insurance, you need tons of data on all of the other things above. On behaviors of people, on the characteristics of people, on characteristics of care, and so on. You have evaluation of health systems. Broad view, is the health system working well or not? Curious thing, if I asked you whether you are satisfied with the Portuguese health system for those that are Portuguese, probably you'll say no, it should be improved. And if I asked you, should we just dismantle the Portuguese health system, probably say no. So you have a kind of ambivalent position with the health system. You like it to be better, but you don't like to ruin it. And so evaluating what is the characteristics of the health system that we care about is also an important part. It's also important because you have to often to face trade-offs involved in it. You have the evaluation of products and services, which some of you probably have already faced if you have developed some tool or some instrument that you think will be useful for diagnostics or for treatment, and you try to sell it to healthcare companies. You're going to face a barrier. They're trying to demonstrate what is the value that you bring. And demonstrating value in healthcare has a very different features if you're trying to do it to a firm that operates in the market, or whether to try to convince the health insurer, the National Health Service, to use it. And those, because they have developed over time features that are related to evaluation in healthcare. Also have the issues about efficiency of organizations. What does it mean? How can we improve healthcare providers' work? And for that we have also something to do. And finally, you have ethics and access to healthcare. I'm not talking about data protection or data regulation on access. I'm talking really the ethics of using it and the opportunities that the new forms of data will bring for crime in healthcare. I'll come to that if I have time in a second. But I'll leave you. If not, then you can ask me what I mean by crime, data, and healthcare, okay? Just to get it easier for you. This means that you're going to have data metering. That will be important, but we're going to need different data for different purposes, okay? So you need to think about what we need on this. Which button does work? This one. Okay. So I try to summarize everything that I don't know, and a few things that I know about health and health economics a bit, and the data part. And I was trying to organize things and think about it. And on data, you can go in health economics. You can go from the small data that will be data on health systems themselves, because there are a few health systems only. You only have a limited number of years or quarters. And if you want to think about overall characteristics of system, you're not going to have large amounts of data. If you want to think about how much to spend in healthcare to increase life expectancy, and you want to make comparisons across countries, you don't have lots of data for that. You have to use aggregate data. That will be the small data part, and it's very common. Our major source today is the OECD health data. But that does not bring you very far. If you may want to make decisions at what we call the meso level. So how to address the healthcare needs and plan the healthcare needs of a population. Take the Alentejo or the Algarve. How to plan facilities for them. How to organize the way they receive healthcare. How to monitor the health of this population. How to address what we call unmet needs on this part. How to manage, how to know the main disease they have. For this, you're going to have other sources of data. You have some surveys, but here you're going to have a problem. Data is usually about something that exists, right? Data implies a register of some form of something. If you're talking about unmet needs, you don't have that register. How do you know whether someone felt sick and has just foregone going for care because of something, because it was too far, because it was too expensive, because it was not worthwhile for some reason? How do we know what was not expressed? And that requires different ways of trying to find out what were those unmet needs. And here probably going to need creativity in understanding how to deal with this source. And maybe, as data scientists, you may have good ideas of how to get these data which are not expressed in the usual way. Then you have what probably you are more used to see around, which is the data from administrative sources that allows you to look on individual decisions, either on treatments or efficient choices of organizations, diagnosis, whatever. These are the electronic medical records. These are the hospital records. Those are the imaging that is popular nowadays with data scientists to find out the progression of cancer. But those are related to organizations. Then you're going to start having new sources of data on individual behaviors and choices. Why do we exercise? When do you exercise? How does that tell you about your health? How does that condition your health? And for that, you're going to have what I call their everyday data. Things that you collect from apps, from smart devices. I guess that my phone is registering that I'm walking back and forth here, right? And it's getting confused what exercise I'm doing. And those things will give you more information. It will be a more granular information, but you need to have some way to understand it and to translate it into actions. So promoting exercise is typically the easier one that you see. But can we get something that will avoid people start smoking? Because usually we talk about smoke cessation, but it's much more effective if you avoid people starting smoking, if you want to avoid lung cancer in the future. That means that working at an early age, between 10 and 15, can we have instruments that will use everyday data to help on this smoking problem, avoiding people to start smoking? And then you have that will be the big data part. Then what I call the deluge data part, which you may argue that's big data, I don't care. It's just too many data for me to understand what's going on. And that's the typical thing here, is you have one human body, you have 50 trillion bacterial cells and 30 trillion human cells in a human body. How they interact and move, it's biology, is the science of life, but how to use those amounts of data, it's incredibly difficult to figure out how to put it into using health economics, which should be, in the future, somewhat useful to look on it. Okay, so that was the only, so that table was the only thing that I needed you to understand. That's what is as much as my knowledge goes, okay? Now, if you want to solve problems in health economics, then you have to start asking what is the problem that you are starting with, okay? And then you have to ask what is the data that you want, and how you can collect it and use. And depending on the problem, the data that you're going to use is going to vary a lot, okay? And so, one important thing on this data part is a discussion that I have had with several people working either in data science or with data that want to use data science. And that's the thing, the only question that I ask is, if we have that data and we use it, how are our actions going to change? So from an economic point of view, the data and analysis only has value if it changes decisions. Okay? And so our critical question is, how are decisions to be changed by using of that particular set of data? So having lots of information and nice ways of separating and analyzing data, but does not change our final decision, has no economic value. Okay? So that means that we need to have in mind what decisions you want to address, what behaviors you want to understand, so that decisions will be different when you're taking a sort of data. So, in a sense, the way, as an health economist, I would like to have a relationship with you data scientists is that you tell me how your data is going to help me understand how people's decisions, either patients, doctors, or whatever organizations, will change with the analysis of the data that you're collecting. Now, one particular thing that may be interesting for you, and those at least that I have digging up two definitions of what is health. Probably if I asked you what was health, some of you may recollect the old WHO definition, which is basically that health is a state of complete physical, mental, and social well-being, and not merely the absence of disease, which is a great definition, but has one problem. According to it, we are all sick. It's difficult that in every time we are in a perfect state of well-being and physical and mental and whatever, right? So this has become a practical issue of how to measure this. Then it becomes a new proposals of health that become quite nice in the sense of practical implications. One of them is this one in the British Medical Journal that says health is the ability to adapt and to self-manage in the face of social, physical, and emotional challenges. Now, to help people be healthy, then you need to address one important thing here: adapt and self-manage, which means decisions of people that will have to be based on data as well, right? They need to understand what are their own characteristics, how they behave as well. And so here you may have lots of opportunities for contribution on this self-management part and this co-decision part. And so the use of data seems to be much helpful with the second definition, but it means also that you need to consider the adapt and manage, which means that you cannot consider only the data by itself. You need to interact that how people are going to understand it, interpret it, and use it. Lay people. Okay? Each of us has a patient or a potential patient. And so that brings a new new opportunities that I may say that will create a new professional category. Data scientists for health improvement. Because one of the things that you see is that in medical curricula, it's now discussed whether they should have some knowledge of data science. But, Jesus, have you looked on the medical curriculum? What the training of doctors has inside it? They need to know about everything. They will take about 25 years before they start seeing a patient, if they do everything. So they will need interfaces between the medical profession and the data science. And that will be a new profession. It's not going to be your core data scientists doing it. There will be something that will be in between, that will know a bit of both sides, that will be able to make the bridge for this. Because in the end, some of the partners in the other side will not be health professionals, will be people. And those will be something to look forward. So what are the most promising uses of new data? And this is the most popular uses that you see around, okay, that I see people discussing. Okay? Imaging and cancer growth, which we find some limitations already. Sometimes too many data points or difficult to understand which algorithms you really want to try and use. And that's one area that's expanding a lot, and probably some of you are working on it. There's also areas related to prevention and behaviors and data collected from wearables, which create new challenges for health economics as well. And one of them is the widely announced possibility of some smart watches can detect if you have a sudden fall and you lay down that you may have cardiac arrest or some arrhythmia, and you may need to be seen by a doctor. The critical issue that has been identified on this side is you can have false positives. So in a sense, your beautiful devices and algorithms and analysis is actually producing harmful results by producing false positives, which drain resources, create anxiety, and may actually lead to undue treatment. On cardiac issues, if you are detected with an arrhythmia, you may be prescribed drugs that will make your blood thinner so that you don't have a clot. But if you have your blood thinner, if you have a cut, you may bleed more. And if you didn't need it in the first place, it may actually be harmful. So you need to be careful about those things. Then you can use data from internet searches, and I guess that Joanna will be here somewhere in the room or someone from a team, and so I have to put, there's, well, you there? So I had to put a cross-reference to them, so then they will buy me lunch afterwards. So that's what's the deal. But you can use unsuspected sources of data to understand the behavior of people, not only the hard part of science. But what else can we have here that are not being considered? First, one challenge for you is that every time that you think about a new product of data science applied to health, is that you consider it or think about where does it fall in one of these three categories. It's going to create the ability to have new services that produce health that was not there before. So it's really new. It's going to be just a replacement of something that existed. And you're just doing better with a different technology, but basically you have the same goal. Or it's just something that you're going to add to what exists. And both of them will coexist in the portfolio of options of or treatment or diagnosis or whatever. And the health economics of each of these three things will be very different. Okay? Most of the time, when people approach me and say, I had a great idea about a new device or a new method or a new way to look on data or to collect new data, they typically fall on replace old services and products. That's where you position your product. And most of the time, it's actually dropping up to the other one in the sense that people will not forego what they do already. They will just add one more thing. And of course, the economics of it and the economics in terms of business case of it is totally different. What is challenging here in the matching of data with health economics is to understand which ones will be in the first block, which ones will change the way healthcare is perceived and how does it change health. And in particular, one tricky element or one piece of things that you can look on it is ask the following question. Does the service or the use of data science that you're going to propose changes the culture of providing the service? If it does not change the culture of providing the service, we fall on the other two. So you really need to have something that's going to be very different. And so that's the critical element for this. Risks. Let's go to the crime. Safety of data. And I'm running out of time. I have 25 seconds. So let me talk about the crime that I was mentioning here. Just a quick example. It's great that nowadays we have devices that stimulate your heart if you have the need for it, that gets the pace of your heartbeat into the right rhythm. So that's good for electric impulse, right? Nowadays it's really nice that you could have bidirectional devices by which you could send signals to someone remotely seeing them, but then correcting the working of the device, going back to the device, right? So bidirectional is probably the way to go. If you have it bidirectional, you have the possibility that someone hacks the system and owns your heart in his computer. Really owns your heart, right? This provides different ways of having crime associated with these things. That is not just the issue of having access to data. That's peanuts compared to holding hostage of 100 patients that have a heart condition. And for that, cybersecurity is going to be a huge thing if you really want to move forward with these approaches. And cybersecurity is probably going to be one of the new dimensions of quality of healthcare that will have to be considered. And health economics can help you understand which are the dimensions that will be more useful, how can you help on that, and so on. Okay? So now I don't have time for more. So I'm going to skip the slides. It's just to say that I have more slides going on if I need it. But usually if I have a captive audience, I can go for 2 hours. So that's why they have the timer here, right? So the last thing I want to do, instead of all this, is just to say, we have a research center that works with health economics and uses data. The previous slides were the data. I'll be happy to send the slides to whoever wants to see them. No commitment whatsoever of contact us. But if you want, you have the QR code, you have the website. We're trying to find a different URL for that, but is negotiating with the IT people. And we'll be happy to answer all of your questions and ideas for collaboration that you may have. Thank you.
Pedro. Thank you very much. Definitely very, very interesting. And